Good morning. Welcome to Breakfast with the Investigators, where our faculty will provide perspectives on current and emerging antibody-drug conjugates for lung cancer. This is our faculty today. I have Dr. Rebecca Heist from Mass General Hospital, Dr. Luis Paz-Ares from the Hospital 12 de Octubre, and my name is Jacob Sands. I'm a medical oncologist at Dana-Farber. And we'll go through quickly. We have so much content to get through. I'm excited to get to the discussion, so we'll quickly click through some of this. In this discussion, we are going to talk about some non-approved use of agents and regimens. We'll go over some of the data from trials, but some of this is forward-looking. Now, Research to Practice is hosting 9 meetings throughout ASCO, so there are multiple, and certainly encourage you to take a look at this and attend many of them to get perspective on all these different cancers. Now, in order to make this more relevant to participants, there was a survey of 50 oncologists that was done, as well as an interview. Dr. Neil Love interviewed 10 oncologists about the topic, and so we are going to see some videos from some of these oncologists, as well as questions from them, and so we'll go through that as well. So this is where we're headed this morning. We'll start out with Dr. Paz-Ares discussing HER2 targeted antibody-drug conjugates, and then I will discuss TROP2 targeted antibody-drug conjugates, and then Dr. Heist will finish things out discussing other promising targets for antibody-drug conjugates for lung cancer. So we'll start with Module 1 here, and I think initially Dr. Gigi Chen will give us.
Good morning, everyone. This is Neil Love from Research to Practice, participating in this year's ASCO meeting virtually. And to prepare for this meeting on antibody-drug conjugates and lung cancer, we did a survey of 50 community-based general medical oncologists over the last few weeks, asking them what they would like to see presented in this meeting, and particularly for specific questions and cases they would like to hear addressed. We asked 10 of these physicians to meet with us in one-on-one hour-long Zoom session recordings and utilize this content to put together a series of short video questions for the faculty on the stage today. Our first topic, the use of antibody-drug conjugates in the management of HER2-positive lung cancer, has become part of one of the most important stories for sure in 2024 that just occurred. The pan-tumor approval of T-DXd, trastuzumab deruxtecan, in patients with any solid tumor with an IHC 3+ overexpression. This is of particular interest in lung cancer, where there's currently an approval for HER2 mutant disease, and now patients also with IHC 3+ will be eligible for this treatment, creating a number of important questions.
First of all, in a patient with advanced lung cancer with HER2 mutation, if the patient prefers not to use chemotherapy upfront, is this a patient that would benefit from using T-DXd in the first line, given that they do have, a mutation that's present? And also along the same line, we usually, for patients who had advanced lung cancer, do the next generation sequencing, to pick up the mutations. But in patients who do not have the HER2 mutation on that next generation sequencing, should we also, as a routine, be checking for HER2 IHC to capture the patients with HER2 2+ or 3+, so they can be eligible for HER2-directed therapy, antibody-drug conjugates? If the initial NGS diagnosis of the patient does not show mutation in ERBB2, what's the likelihood of the patient later on acquire this mutation at progression?
So important and challenging questions. We've had, so it was very clear before, HER2 mutant was the lung cancer outlier, right? In breast cancer expression, in lung cancer, just HER2 mutation. Now with HER2 expression, 3+, what are your thoughts on this?
Okay, so I would say this is really good news that we are having some targeted therapy, some specific therapy for those patients, for patients with HER2 mutations and patients with HER2 overexpression. So let's say, I think I would consider for those patients that are overexpress HER2 in the pre-treatment, in patients that are pre-treated, that is something that I will consider for all my patients in the future. So I would think that into the future we will do a lot of immunohistochemistry screening on those patients. That, of course, will compete down the line with other ADCs and potential therapies, but I would like to have all the information and choose the right treatment for my patient. For those patients who have HER2 mutation, we will discuss the data. We don't have extensive data on the first line in untreated patients. It will be an ongoing trial because of the really good data that we have already collected with patients previously treated with chemotherapy.
So in that setting, HER2 mutant, then the first question, where in the sequence are you offering this? Are you considering this as a first-line treatment for patients? Are you doing it second line?
So that is going to depend on the label on your area, but that would be something I would consider first line. But as I said, it would be a trial dedicated to that specifically. And of course, be aware that there are some other therapies as well developing this setting. So we'll have to see which is better to start with the ADC or maybe, and then having second line a TKI, or maybe having the reverse sequence for patients. We'll see. I don't think we have a clear answer for those questions as yet.
So, Becca, in your practice, trastuzumab deruxtecan, first line for any patients? Is there a certain patient profile where you consider that, or is it?
So I typically offer it in the second line setting. I am usually using chemotherapy first line, and then chemo IO, and then if progressing, going to trastuzumab deruxtecan. That is the label in the United States. I think if somebody truly refused standard first-line therapy, I would certainly reach for it. But I would also try to talk them into first-line therapy, because I do think first-line therapy has benefit.
Now, going back to that first part, are you looking at HER2 expression in your patients?
At this stage, I'm European, so we are not having the drug approved as yet there for those patients overexpressing. So we're just checking that when patient is available to enter in a clinical trial. But, thinking on the future, when this ADC, maybe some others are approved, I think we will check for all the potential biomarkers so that for each specific patient, we'll try to offer which is available for them.
So I recently asked for this on a patient of mine because we had done various standard therapies, and I wanted to see if HER2 overexpression was going to open this up as a treatment option. We are not currently doing this in the first-line setting, but with this approval, we will probably start to add this to the range of things that we check for.
Okay, so preparing for it, though, it sounds like.
Yep.
Okay. And then the response rate within this, how does that kind of push you as to where you're offering this regimen, first line or second line? Assuming you have access to the drug at any point, what are your thoughts on response rates?
So, looking at the data, response rate seems to me somehow higher as compared to that we typically get with chemotherapy. Safety-wise, things are fine as well, I would say, for most of the cases, particularly using the right dose, as we will see in a minute. And so that would be my intention. It is nice that there is a dedicated trial that is actually going to answer for us that question, and I think it's important to have robust answers to important questions.
I think one of the things that kind of pushes this drug earlier in therapy to first line is very often patients who have HER2 mutations have never smoking history as well. And so in that setting, that question of the PD-1, PD-L1 inhibitor, how much is that benefiting, is a little bit more questionable than for some of our other patients. And so there you don't feel as much like I'm giving up this really potential prolonged benefit from immunotherapy. And that pushes a drug like trastuzumab deruxtecan up, where the response rate is so high and the activity is good.
So that's actually exactly the population I was thinking when I was saying, is there a subpopulation where you'd consider more? I think someone without a smoking history, as you say, I'm less expecting of some kind of immunotherapy response, no matter what the PD-L1 expression is. Certainly in someone with a smoking history, these checkpoint inhibitors, we see such durable responses in a subpopulation. But in someone without a smoking history, I think the standard of care is less appealing.
I mean, and 2/3 of the patients are actually never smokers, and the benefit of immunotherapy on that very population, at least in some retrospective studies, is, I would say, at least doubtful. So I'm actually very often using chemo instead of chemo-IO in this very population of never smokers.
Okay, let's move along then. We have another video here.
When any new agent comes on the oncology scene, of course, one key question is tolerability and toxicity. And in terms of TDXD, of course, this is a very complicated question, not only because of acute chemo-like side effects, but more importantly, the risk of interstitial lung disease. And our consulting oncologists already have extensive experience with TDXD in breast cancer and want to know how to apply it in the lung cancer situation.
We have quite a bit of experience with TDXD in the breast setting, but I feel quite worried about using TDXD in lung cancer patients. They tend to be smokers. They could have COPD. They have lung masses sitting near very vital organs and near the hilum. So, it makes me wonder what kind of effect would TDXD have on these lung cancer patients? Some of these patients have had radiation as well. And then if I do use that for these lung cancer patients, then how often do I do imaging? For example, in breast, we do it every 9 weeks. I mean, you stop at grade 1 toxicity. If the patient's responding, they have underlying COPD, and now they've developed grade 1 pneumonitis from TDXD, you don't know what to do. Is there a chance that you could re-challenge once you're done treating it?
I know that it scares me, and I think for most community-based oncologists, you asked previously where a hepatologist comes in. Hepatologists are hard to come by. Pulmonologists are not. And that takes down my level of concern for these particular agents to some degree, because I know we've got someone who's going to be able to help me take care of those patients if they have those kind of side effects.
Just like in immunotherapy, and even with radiation to the lung, sometimes it's very difficult to tell what's causing pneumonitis or what are the symptoms of pneumonitis. So I think those challenges are very similar in parallel, where it takes a combination of time to see the side effect declare itself and trying empiric steroids and having a pulmonologist involved to consider the threshold for a bronchoscopy. So I think that will always remain somewhat of a clinical challenge in needing physician judgment.
How do you manage acute toxicity, and how do you prepare patients? For example, managing nausea, which I have patients that have had very pronounced nausea on this regimen. How do you manage potential toxicity with cytopenias and fatigue?
All right, so we're going to get into this a bit when we get into the Dato-DXd as well. We have the same payload, similar toxicities, but just as a brief statement with trastuzumab deruxtecan, are there certain toxicities that you're most attentive to, most concerned about, and how are you managing those?
So I would say, particularly using the right dose, let's say, you're getting some hematological toxicity. That is not a big issue. It's not different than any other myelotoxicity from other chemotherapy, neutropenia, thrombocytopenia, anemia, and so on. You get some general nausea, vomiting, fatigue. Same thing here. The very big particular toxicity, I would say, is pneumonitis, has been said here. So using the low dose, and we will have some data on that, the incidence is much lower. Particularly, you have to be really careful at doing CT scans on a regular basis and watch out. If the patient is developed pneumonitis, you have to stop treatment and consult a pulmonologist, be sure that it's a pneumonitis, that not anything else, and then start steroids for that patient particularly. Doing so and starting that very early, recognizing very early, I don't think it's a big issue for most of the cases. the term of the fact of re-challenge or not, I mean, for most of the cases, I don't think we are going to re-challenge those patients unless the toxicity is completely solved and you really feel very much the patient is benefiting. But those cases are going to be quite rare, at least in my opinion.
So you're talking about symptomatic, not grade 1 necessarily, but more symptomatic, grade 2, grade 3, suspected.
When I'm getting grade 1, I'm checking how the patient it is very carefully just to be sure that this is not that is increasing, I would say.
So grade 1, meaning you're seeing something on a scan that looks inflammatory, but patient has no symptoms. I think that's a gray area.
Yeah.
The trials would generally allow for holding, but then restarting after things clear.
Yeah.
Symptomatic grade 2 is where things really were stopped. I know I'm going to move us along because we're going to discuss this quite a bit more, I think, with TROP2, and I think there's a lot of overlap when we're talking about trastuzumab deruxtecan and datopotamab deruxtecan that we can get into. And so for now, I'll move us along to Luis's talk.
Okay, so thank you very much. And 1 second, okay. So we have mentioned here that HER2 is one of the 4 components of the EGFR family of receptors, which are very important in the biology of many cells, including tumor cells, particularly epithelial cells. And of course, there are some molecular alterations on those receptors, particularly the HER2 receptors, that are actually impacting the behavior of the cells. Concerning HER2, HER2 mutations are happening in some 2% of the cases, typically in heavy smokers or lighter smokers. HER2 amplification in some 10% of the cases, 10 to 15%. The impact on the biology of the tumor cells is not as high as mutation, of course, and some 1/4 or 1/5 of the patients do have overexpression of the protein. So trastuzumab is an ADC with a humanized antibody, with high affinity to the HER2 molecule, and it has a payload, which is a potent topo-1 inhibitor, deruxtecan, an exatecan derivative, and it's having a linker, a tetrapeptide cleavable linker, and of course the antibody, the drug-antibody ratio is about 8, quite high, so a lot of molecules of the payload per each compound. And I'm just going to briefly review the data we have so far. Concerning those 2% of the patients with HER2 mutations, the initial study on the DESTINY-Lung01 had a cohort of patients with mutation. In those 91 patients, typically heavily pretreated, response rate was more than 50%, 15%, and PFS more than 8 months, and overall survival about 1.5 years. 18 months. That told the data that maybe you should have in your mind. Then there was a second trial where patients were randomized to do 2 doses, 5.4 milligrams per kg every 3 weeks, and the high dose, 6.4 milligrams per kg every 3 weeks. Those were patients previously treated with chemotherapy, at least 1 prior line, and of course, metastatic lung cancer with HER2 mutation, activating HER2 mutation. The study was set up for about 150 patients. The initial, let's say, analysis was with 80 patients. Remember, you see here the data. Responses were seen in about 50% of the cases, again, as in the initial study, 49% for the low dose, 56% for the high dose of 6.4. And you see here, PFS, median PFS was in the range of 10 to 12 months, more or less, in the 2 doses. And overall survival had a median overall survival of about 18 to 20 months in the 2 cohorts. Here you see the final results. Responses in 56% of the cases, median PFS 10 to 12 months, and median OS in the range of 18 months again, and those are the data. As you see here, no major difference by the dose. However, when you go to the toxicity, you see here that overall, the grade 3 toxicities are not very important, but the number of grade 3 toxicities are clearly higher with a high dose. So you see, like, for example, anemia, 10% as compared to 16%, leukopenia, 5 versus 16%, and neutropenia, 18 versus 36%. More importantly, you look at the data in terms of adjudicated ILD for those patients that didn't receive prior PD-1 therapy. On the table below, you see that the percentage was 7% with the low dose, 5.4 milligrams per kilogram, as compared to 27%, 4 times higher with a high dose. For those patients that did receive prior anti-PD-1 therapy, the proportion of ILD was 14% for the low dose and 28% for the high dose. So a huge difference here. And if you look at the table below, you see that most of the cases were actually grade 1 or 2 for the low dose, and I think that is somehow reassuring. So the proportion of expected ILD is going to be more on the low, 5 to 10%, and typically grade 1 or 2 for most of the cases. The other cohort of patients that have been studied in the LANO-1 study are those with overexpression. There was a cohort of patients with overexpression, 2 pluses and 3 pluses, previously treated with chemotherapy. Responses were seen in that trial in 26% of the patients treated with the low dose and 34% treated with a high dose. And you see here the PFS in the range of 6 months for each dose, no difference at all. And the median survival was in the range of 12 months, also without clear difference between those. So 30% of the patients responding, PFS 6 months, survival 12 months. That's very much the bottom line for those patients that had a overexpression. As Dr. Sands mentioned before, well, the safety profile is very much the same. I'm not going to go over it again. And as Dr. Sands mentioned before, there is a FDA approval for those patients with 3+ overexpression. That is based on 3 trials, and of course includes lung cancer patients, so that is an opportunity for your patients. So there are a number of trials ongoing that I think are going to be important into the future to tell us where is better collocated the role of the trastuzumab deruxtecan in the setting of lung cancer. And there are some trials that are comparing trastuzumab deruxtecan with PD-L1 inhibitors, for example, durvalumab in that case, but also with other drugs, and also with bispecific drugs, but also with chemotherapy as well. This is a phase 1 trial, as you see here. Maybe more important is the the Destiny LANO-4 trial. It's a phase 3 trial that is going to give us a very important answer. This is patients with unresectable advanced HER2 mutant lung cancer with no prior systemic therapy, so treatment-naive. Patients are randomized to receive a standard of care therapy like platinum pimitracet plus pembro versus trastuzumab, and I think this is a very important trial to tell us where to put the drug. So this is very much what I like to say, but we can maybe answer any controversy I have created during my talk.
Excellent. Thank you for taking us through that. Now, that answers some of the questions that we had and some of the discussion we had to begin with. The toxicity profile, we'll get into in a moment, actually, because we're going to have another video from Dr. Chen here, and we can then discuss some of the tox profile.
The focal point for many trials of ADCs has been second-line therapy in patients with non-small cell lung cancer without targetable mutations who receive immunotherapy plus or minus chemotherapy in the first-line setting, as demonstrated by a case from Dr. Gigi Chen.
This is a 53-year-old male, and he had a history of stage 1B squamous cell cancer, and he underwent resection and then followed by cisplatin docetaxel adjuvant chemotherapy. He then, about 2 years later, had a recurrence. At that time, the molecular testing did not find any targetable mutation, so he was treated with pembrolizumab, carboplatin, and nab-paclitaxel. He now, a year later, has progression of the disease. So in this setting, what will be the best next line of therapy? Given the new data, in terms of the TROP2 targeted antibody-drug conjugates, such as Dato-DXd, would he be a good candidate for the TROP2 targeted ADC in this setting? Or does one need to check for overexpression of the TROP2 c-Met for these new classes of the ADC? How does one sequence the lines of therapies utilizing these ADCs?
So, Dr. Heist, you also have a lot of experience with TROP2 antibody-drug conjugates. How do you think about where we sequence these, assuming, right now this is on trials, but assuming this was all available, what are your thoughts?
Yeah, if these were FDA approved, which of course right now they're not for lung cancer, I think one question for this particular case is I think the patient had squamous cell cancer. And so particularly for datopotamab deruxtecan from the TROPION-Lung01, and I'm sure you'll go over this data, the data did not look as good in squamous, so I would shy away from that particular drug in this setting. I don't think there was a similar finding with sacituzumab govitecan, so that is a potential option. But docetaxel also has fared quite well in many second-line direct comparison studies, so would be a potential option as well. I think if the patient had non-squamous, I would be more enthusiastic about a drug like Dato-DXd here.
Yeah, important point. And this brings up now, then, you just presented yesterday sacituzumab govitecan. This is these two drugs on paper the same. I mean, antibody to TROP2, a cleavable linker, topoisomerase inhibitor, Dato-DXd, which we'll get into, not really effective in squamous, but sacituzumab govitecan, similar efficacy in squamous and non-squamous. The big question is why?
Well, honestly, there are a number of uncertainties here. The first one is, of course, the drugs do share the antigen, the target, and they have payloads that are topo ones, but there are a number of differences, particularly into the construct, which are very important for the activity of the drug. Secondly, they are different, and it's very easy to see that the tox profile is quite different.
Yeah.
And third, the data we have so far are still limited. So honestly, I don't think we understand why the data ADC is not active in squamous cell carcinoma patients. The data with sacituzumab suggests that the drug is as active in squamous as compared to non-squamous. It's not only in that trial, in the first-line trial ongoing, the EVOKE-02, the data are very similar as well. This is a phase 2 single arm without randomization, but the data suggests that there is similar activity in squamous as compared to non-squamous. So I think we have to understand what is the basis for sensitivity of resistance in squamous in this patient population. We have to confirm those data. The only thing we can say is that the patients that are particularly sensitive are those with underlying genomic aberrations. Because all over the trials with Dato, with sacituzumab, whatever, this patient population is the one doing the best, right?
Yeah. All right, I promised discussing toxicity.
Okay.
So I'm going to clump trastuzumab deruxtecan, datopotamab deruxtecan with the deruxtecan payload. Dr. Heist, what are you monitoring for? What are toxicities that you're particularly aware of or concerned about, and how are you managing those? And highlight between trastuzumab deruxtecan and datopotamab deruxtecan. If there are differences relevant to that, please specify.
Yeah, so for Dato-DXd, we see much less of the hematologic toxicities. That's much less of a concern. We do see, unlike with trastuzumab deruxtecan, some stomatitis. And that is actually quite challenging to manage. It requires a fair amount of, I think, prophylaxis and prevention to try to prevent people from getting to a point where the stomatitis is very bad and affecting the way they're eating. And so we use all sorts of rinses. Some of the steroid rinses seem to work perhaps better than others. And so that is something that I definitely think about proactively managing. And then a similar toxicity, of course, is the pneumonitis ILD, which can occur with this drug as well. And the one thing I would say is when I see a grade 1 ILD pneumonitis on a scan, I will always take the O2 sat and walk with the patient. I actually find that incredibly helpful because a lot of times patients don't necessarily tell you, or it can be hard to tease out. They've always been short of breath. They have lung cancer. They're short of breath at baseline, and they have dyspnea on exertion at baseline. And so walking with the patient and just seeing the O2 sat, whether it stays stable or drops, is actually very informative.
That's a great pearl. You're the first person I've heard mention that, getting a walking O2 sat. Do you do that at baseline as well?
I should. I think it strikes me to do it when I see something inflammatory, but I think actually I should start doing that. Thank you.
I think that's a great statement. All right. Let's see. Dr. Paz-Ares, anything that you'd like to add about the stomatitis in particular?
Well, yeah. So actually, I have to say that stomatitis is typically grade 1 or 2, but can be, let's say, an issue for the patient. So it's very important to recognize it early. If you need to actually dose delay, do it. Do not start therapy, the new course of the patient having grade 2, for example, is not a good idea. Second thing important are the steroid rinses. Actually, sometimes it's difficult to get it in the local pharmacy, so be sure that your patient is having that rinse available, and I think that's very important. And the third thing is that monitor that from the very beginning, very early on, because this is a toxicity that oncologists very often we are not very used to handle, so it's very important. The same is true actually for the ophthalmological issues, so you have to really have a fast track with your ophthalmologist. At least in my clinic, it's not easy to get an appointment in 1 or 2 days. So this is something we have to work as we did 10 years ago or 20 years ago with our dermatologist. So this is something that's going to be of help for our patients.
Yeah, it's a good point. And I think early request for consult with ophthalmology before it's really necessary is that's a good thought. Okay, so I'll jump into TROP2 antibody-drug conjugates. And, we've discussed some of this already, so I'll kind of breeze through aspects of this, but you have the slides. First of all, TROP2 expression looks to potentially be a poor prognostic marker. It's not expressed in normal tissue, and so this is something that looks to be a good target. So we'll get into some of the data. Sacituzumab govitecan and TROP2 ADC, both of those, and Dato-DXd, both are TROP2 antibody-drug conjugates with a topoisomerase 1 inhibitor payload. In both cases, that payload has what's called bystander effect. So the drug binds to TROP2 on the receptor of the tumor cells, gets pulled in, releases the payload. When the apoptosis of that cell happens and there's spillage then of that payload into surrounding tissues, it is membrane permeable, so it can cross the membranes of surrounding cells that don't necessarily have TROP2 expression as well. And so this is how it can have what's called bystander effect. Say on paper, these are very similar drugs, but we'll go into the data a little bit. So first of all, looking at PanTumor01. So this is an earlier study looking at dose escalation and then the dose expansion cohort you can see on the right there. The point of this slide is really that the efficacy for the different dose levels is similar. So 4 milligrams per kilogram, 6 milligrams per kilogram, 8 milligrams per kilogram, all of those have similar efficacy. Now, the point I'm making with this that we'll come back to is, unlike some other drugs, a dose reduction doesn't seem like the end of the world. So stomatitis ends up being a really big problem, having trouble managing it. I'm okay with a dose reduction, and I think there's some reassurance, although the numbers aren't huge. There are 50 patients in the dose level, in the lower dose level. There's some reassurance that you're not losing efficacy. There are some other drugs where we see a drop-off in efficacy. Now, TROPION-Lung01, this was the big one we saw presented at ESMO in October by Dr. Lisberg, second line. Well, so second line if the patient did not have an actionable genomic alteration and got chemo-immuno in the first line. Those with actionable genomic alterations got targeted therapy and then also got chemotherapy before they went into this trial. Now, the progression-free survival of the total population was positive. This was a positive trial for overall population. That being said, when we split it into squamous and non-squamous, in the squamous it actually appears detrimental, where the docetaxel arm did better. In non-squamous is where we see a more clinically meaningful benefit of about 2 months improvement in progression-free survival and a response rate that more than doubles, a duration of response of a couple more months as well. The interim overall survival you see here for the full population as well, and that will be updated. We've talked about toxicities a bit, and certainly we see some of that with Dato-DXd, not as much of the chemo stuff, but more so stomatitis, ocular, eye surface toxicities, and then ILD. One thing I'll point out on here is that there were some grade 5 ILD events, and so this is something that absolutely needs to be discussed with patients. There also was ILD noted in docetaxel, so this is not necessarily something that is not seen in any other regimens, but this is a highlight of this drug, is that it can cause ILD. The one thing I'll point out, though, is you see on the right there that 7 the grade 5 events, the primary investigator attributed 4 of those to disease progression, which is, it's hard to know. And so when you see something that looks like it could be ILD, I would say, one, have attention to the fact that that could be ILD, but also don't just immediately conclude that this is in fact drug-related ILD. I think it requires then considering some kind of workup and not missing other potential causes. When there's such consistent difference between the primary investigator and the adjudication committee, it highlights what a challenging topic that is. Now, Tropion-Lung05, this is for those with actionable genomic alterations. You see in the pie chart, many of those were EGFR. And we really saw quite good responses. The waterfall plot looking like what we see with some of our targeted therapy waterfall plots. And from the spider plot there, it's to highlight the fact that even some patients, that you see some real durability, even in some cases with not a tremendous amount of tumor shrinking. We also saw this with some of the stable disease, where there can be, in some cases, real durability, even when it's stable, which is to say that the benefit can extend a little bit beyond even what's the response rate. That's true for multiple different drugs, and I think increasingly being highlighted. Toxicity profile is what we've seen across the board. So Tropion-Lung02 was combination Pembro and Dato-DXd, and this then feeds into trials that are underway. That is the justification then for our first-line trials. I've highlighted 3 Dato-DXd first-line trials. Of course, we also have the sacituzumab govitecan, EVOKE-03, which is Pembro plus minus Saci. Now, we had an excellent talk yesterday. We put the slides together ahead of time. So from the press release, we knew that it did not meet overall survival endpoint. And yesterday, we got some more nuance to this. Essentially, progression-free survival of the whole population was a hazard ratio of 0.92, so no real difference. In the overall survival, the hazard ratio was 0.84. But interestingly, in those that had a prior immunotherapy response, actually didn't seem to do as well. But in those without prior immunotherapy responses, where we saw potentially a signal somewhat hypothesis generating. EVOKE-02 was combination Pembro, sacituzumab govitecan. I put this up here. I mean, that combination is what's going forward in trials of the EVOKE-03, but you can see from the toxicity profile here, that's quite different from what we see with Dato-DXd. So there's still a lot to discover, and on paper, as I've said, these are very similar drugs, but we see differences in efficacy, we see differences in toxicity, which highlights there's still a lot to know. So I developed this figure as a way of discussing concepts and how clinically useful a drug is. And so just briefly, I'll point out this hexagon goes from a score of 0 to 5. You can see the 6 points being median overall survival, median progression-free survival, the dosing schedule, which is essentially a time toxicity, duration of response, drug toxicity profile, and overall response rate. And if you rate each of those from 0 to 5, here's an example. Now, I didn't go into great depth as far as exactly how to score this. This is just for concept discussion. But if you see, this is a score of, on the right there, docetaxel has a 2 for median overall survival, a 2 for median progression-free survival, and so on. And then connecting those. It gives you a size of a shape, which is then your impression of how clinically useful this is. Immunotherapy, duration of response can be quite good. Toxicity profile generally good. Response rate not high. And so when you see this, I'd encourage you, I specifically did not put what I think for the TROP2 ADCs, because I encourage you to score it yourself. Score for yourself, how is docetaxel and how are these TROP2 ADCs? And therefore you get an image then of how clinically meaningful you think this is. But certainly a lot still to discuss. And I think that might bring us actually right into the other promising targets. I think we have another video here.
Another interesting area of investigation of ADCs in non-small cell lung cancer involves patients who receive osimertinib as first-line therapy for metastatic disease, but then have disease progression. And both patritumab deruxtecan and dato-deruxtecan have been investigated in this scenario.
This is a guy I've been following now for, about 4 years, presented quite ill with metastatic cancer, got him settled down on osimertinib. He did require, because he was quite sick, a couple doses of chemotherapy up front. He was on osimertinib, did well, progressed, and was able to get him patritumab on expanded access. He did well for about a year as controlling his disease, but to be honest, he's a young, fit, healthy, exercise, plays pickleball, plays tennis. I was somewhat surprised about the toxicity. It was true chemotherapy toxicity, and at least in this gentleman, it was harder to tolerate than carboplatin and pemetrexate. Fatigue, tiredness, nausea, and then as we do frequent CT scans, he started to develop on imaging studies, at least some infiltrates that were concerning for pneumonitis in the setting of disease that might have been slowly progressing, so he was taken off of that.
I have a 42-year-old woman that presents with shortness of breath, and we found that she has an EGFR mutation. And before we can start her on treatment, she develops tamponade symptoms, is admitted to the hospital acutely. She had a large burden of disease because she was bone, brain, 2 lesions, and a lot of respiratory symptoms with tamponade. We ended up managing her with chemotherapy, a little biased, thinking that chemotherapy will kind of sort of reduce her faster. And I was also impressed that in the FLAURA2 regimen, there was significant CNS activity that was improved with adding chemotherapy, mainly pemetrexed up front for patients with EGFR mutation. Now that we are using chemotherapy up front in more patients with EGFR mutation based on the FLAURA2 data, in the second-line setting, what are the best options? Can we use ADCs for patients that have now progressed on chemotherapy and an osimertinib TKI?
So the EGFR space has become increasingly complicated. We had some good data yesterday with amivantamab subcutaneous, reduced some of the toxicity profile a bit. Dr. Heist, where does patritumab deruxtecan fit into this? Assuming you have access to it, would you use it? Where would you use it? How does it fit into the landscape?
Yeah, I would certainly use it. I would consider it after osimertinib and chemotherapy, whether you give it sequentially or together as you might with FLAURA2. And I think patritumab deruxtecan, if it were available, would be a very good choice at that point. We'll see some data that also shows CNS activity, which is very nice. I think one question is with the dato-DXd data, how do you sequence that? And I don't have an answer to that.
Yeah, so patritumab deruxtecan, datopotamab deruxtecan, both of them have pretty good efficacy in the EGFR space. Dato-DXd data for other actionable genomic alterations more so as well. I mean, there's a bit more data for others. How do you compare those two? What are your thoughts on that?
Well, I mean, I think I would follow the same strategy. I would likely place it after chemo plus osimertinib, concurrent or on a sequential basis. And I would trend to use more patri deruxtecan as compared to dato deruxtecan in this setting, because I think safety-wise, is much easier for the patient. That would be my bias, even they are not being compared, let's say, back to back, but that would be my preference as today.
Yeah, it seems like a little bit of a toss-up to me. I did find it interesting. So after ESMO, a lot of the discussion was osimertinib versus chemo-osimertinib, a la FLAURA2, and then amivantamab lazertinib, and do you do that after chemo? There was an excellent talk, I think it was Zosha Piotrowska, that gave a great talk highlighting the different possible tracks on that. But one thing was missing was datopotamab deruxtecan or patritumab deruxtecan fitting in there. And I can't say I have a strong preference about either, but I do think that that this is absolutely something to consider. But patritumab deruxtecan versus datopotamab deruxtecan is certainly something we could debate. How about c-MET expression? Is this something that you recommend testing for, Dr. Heist?
This is still in the theoretical space right now because there is no MET ADC that currently has an FDA approval. But I think we will see interesting data at this year's ASCO, actually. And certainly, if we see an FDA approval, I would be testing for MET overexpression. And we do right now in the targeted oncogene resistance space, right? Because we know that MET overexpression and amplification is a mechanism of resistance that's important to know about as you think about treatment in that space. I think in the de novo first-line treatment of metastatic lung cancer or second-line treatment with one of those oncogenes, is there space for a MET ADC? I hope so, because I think it would be the more treatments we have available for our patients, the better. And so certainly would be testing if that were the case.
So along those lines, if you had telisotuzumab vedotin compared to docetaxel, what are your thoughts on that comparison?
So there is a study comparing, and so we'll have to see how that pans out.
What do you anticipate is what we're...
It's hard to know. I am... So that study is specifically selecting by MET overexpression. So you would hope that with a biomarker-selected strategy that you could beat docetaxel in that setting. So that's certainly my hope, but we need to see what the data shows.
So if I can jump in, so I think into the future when maybe we will have 3, 4, 5 ADCs available against different targets, that is going to be part of the relevant information. The other part of the information which is important is to which payload is more likely the given tumor to respond. Mm-hmm. And I think we have to explore a bit more the biomarkers of response related to the payload, because at the end of the day, I don't think it's the same having the same target but with an intramucotublar payload as compared to a topo-1, compared to a pro-apoptotic or whatever. So that is going to be a second part of the question that is not being fully studied as yet.
Yeah, it does feel a bit like, in the lung cancer space, antibody-drug conjugates are fairly new for us. We have an explosion of different ones, but of course these have been around for other tumor types. But it does feel like we're still in kind of an extension of first generation, and we now have a platform upon which all the payloads we're talking about are chemo payloads, essentially. But it does seem like I anticipate there will be others and interested in next generations as they come along. But going back to our discussion, toxicity profile. So we don't yet have efficacy data. What are your thoughts on toxicity profile? Anything to particularly be attentive to as we're looking at data?
Yeah, I think one of the things to pay attention to is peripheral neuropathy, actually, that stands out for this ADC as compared to the other ones where we didn't really see much of that at all. So that's definitely something I pay attention to and try to manage as treatment goes on.
Any aspect of this around quality of life that you'd like to highlight?
Certainly peripheral neuropathy we're familiar with from chemotherapy, and if it progresses quite severely, if people are having trouble with balance, if it's peripheral neuropathy in their feet or troubles with fine motor, you don't want to let things get to that level. So that's something to pay attention to.
I would add the MET inhibition class of effects like edema, hypoalbuminemia, and so on. Maybe not as strong as with other agents, but still somehow there.
Yeah. We talk about docetaxel being so hard to beat, but docetaxel is quite toxic. I feel like there are certain quality of life aspects to beating docetaxel where it's not, we say it's been a low bar but hard to jump. But some of that I think is we're not being so attentive to the toxicity profiles across these. We see these charts that shows many grade 1, 2 toxicities. One of the things I've recently been thinking about is that we need a swimmer's plot of some of these toxicities. Now in neuropathy, if that's not going away, that's gonna show up more versus some grade 1 nausea that ends up being for 2 days with each cycle, for example, or in the case of sacituzumab govitecan, maybe diarrhea, it's a high percentage of patients that are diarrhea, but maybe 3 days and then it's gone. How do you feel like this would stack up or look next to docetaxel in like a toxicity swimmer's plot?
That's a great question. I mean, in my mind, it would look a little better, but I haven't experienced either, so I don't really know.
Yeah.
But I think kind of ongoing quality of life assessments as these studies are being done are super important, as you're saying.
Yeah, I mean, you look, for example, to the EVOCO-1 study. I mean, the number of patients having discontinuation due to adverse events were actually nearly twice as much for docetaxel as compared to saci-govitecan. And indeed, the duration, the number of patients that had treatment for 6 months or longer were twice as much, 33% as compared to 17%. And the thing is, when you look at the PROs, in most of the domains, there was a gain in terms of time without symptoms, without symptom deterioration when treated. So I think the composite of not much tox or maybe having some control of the disease, both things are responsible for this somehow improvement in terms of PROs.
Yeah. Okay, so that leads us into Dr. Heist. Give us more information on this topic.
Sure. So we're going to dive into other promising targets for ADCs in lung cancer. And so first, HER3, and we started to talk about this during the discussion. So HER3, as you all know, is a member of the HER-ERB family of receptor tyrosine kinases. It itself forms heterodimers with other receptors and has minimal intrinsic kinase activity. It is expressed in the majority of non-small cell lung cancers, and in metastatic disease has been associated with poor prognosis as well as metastatic progression. HER3 overexpression has been implicated in resistance to multiple types of treatment, including an EGFR. And you can see patritumab deruxtecan, the schema for the ADC there. This is an anti-HER3 IgG1 antibody that's linked via this linker to deruxtecan, a topoisomerase 1 inhibitor payload, similar to some of the other payloads we've seen before. This is the HER3 Lung-01 study schema. This took patients with advanced lung cancer with EGFR mutations, required to have prior EGFR TKI and prior platinum-based chemotherapy. There was an amendment to this study to require OC as the prior TKI. And ultimately, patients were treated with patritumab deruxtecan at the fixed dose of 5.6 mg per kg for the vast majority of patients. And here's the waterfall plot, the overall objective response rate of 29.8%. You can see the majority of patients having some shrinkage in the extent of their tumors. I think interesting to note, these responses were seen across the range of different EGFR sensitizing mutations that were the original oncogene mutation. They were also seen across a range of EGFR resistance mechanisms, whether EGFR dependent or independent, and also across HER3 expression levels. And that, to me, is actually a plus of a drug like this, that we start to subdivide treatments at resistance into very, very small pieces of the pie of this particular molecular mechanism is why things are becoming resistant. We're going to go down this narrow pathway. Here's another. And this is a more global, in the resistance setting, there may be activity. And here's the adverse event profile that we talked about as being very important for all of these drugs. You can see the most common AEs shown on the left, nausea, thrombocytopenia. There are cell count decreases. You can see the majority of these are of low grade, but there are some grade 3 and higher toxicities as well. You can see the rates of AEs that were associated with treatment discontinuation is relatively low, around 8%. About 22% were associated with dose reduction, and a higher percentage with dose interruption. ILD is seen with this drug as well. Patritumab deruxtecan does have ILD, and you can see the rates of that here as well. As we mentioned before, there have been more analyses looking at CNS activity of patritumab deruxtecan, and this is an area where I think this is a real good news story for us. I think going into the whole realm of ADCs, because of the size of the molecule, there wasn't that much expectation, in all honesty, that there might be CNS activity, but there have been various analyses done of several of these ADCs that do show that there is some activity in the CNS. So this is some subsequent analyses that were done looking at CNS activity for patritumab deruxtecan. And you can see specifically in patients whose baseline brain mets had not been radiated, and there are about 30 of these patients, the response rate in the CNS was about 33%. It's very similar to the systemic response rate. And to me, it's very encouraging because very often when we're facing treatment choices with a patient, we are also thinking about what do I do to best control their brain mets. They may have some slight progression in brain mets. They may have brain mets that have been treated, but you know you would like to have a drug with CNS activity. So that is a plus of any drug in this setting. So the phase 3 HERTHENA-Lung02 study design is shown here. This is for metastatic non-small cell with EGFR mutations, received TKI, including a third generation EGFR TKI, and randomized to receive patritumab deruxtecan or platinum-based chemotherapy. Moving on to a different target, c-Met overexpression. This is something we've known about for decades, that MET overexpression happens across many different cancer types, including in lung cancer. We think it's generally associated with poor prognosis. And telosotumab vedotin is a drug which is a MET ADC. This targets c-Met via the antibody, which is telisotuzumab. It's linked via a cleavable linker to the cytotoxic payload MMAE, which is a microtubule inhibitor. And the phase 2 luminosity study design is shown here. This had multiple cohorts, squamous, non-squamous, and then within non-squamous, EGFR wild type and EGFR mutated, and then further subdivided into different levels of MET overexpression. And we saw a couple of ASCOs ago the objective response rates seen in this setting, and there were differing response rates according to the various different cohorts, with the highest response rate seen in the EGFR wild-type non-squamous c-Met high population, but also response rates that looked promising in the moderate expressing wild-type non-squamous population. There was a press release recently that updated these data, and at this year's ASCO, in the next couple of days, we'll, I think, see some of these data presented, so we'll have some updated data. And then AEs we talked about as well, the treatment emergent AEs seen with this drug, the most common being peripheral sensory neuropathy, also nausea. As a class, the MET inhibitors do cause hyperalbuminemia and peripheral edema, and we see that as well. And the phase 3 telemet study, this is the trial I was referring to. This is selecting patients with some level of c-Met overexpression with EGFR wild-type non-squamous histology and randomization to Teliso-V versus docetaxel. And these results we await to see how does this fare in this biomarker-selected comparison. And then finally, B7H3. This is a marker that's overexpressed actually in a broad range of cancer types, thought to have an immunomodulatory role and associated with cancer progression and poor survival. Ifinatamab, I can never say this, IDXD, is an antibody-drug conjugate with the B7H3 IgG1 antibody linked via a cleavable linker to, again, the topoisomerase 1 payload deruxtecan with a DAR of about 4. This was the phase 1 study design looking at dose escalation of this drug in multiple different solid tumors. And you can see the cohorts listed there. And there was a subgroup analysis of the patients with small cell lung cancer from the part 1 dose escalation. There are about 22 patients with small cell enrolled in dose escalation. And among those patients, you can see this in small cell is a waterfall plot that shows a very nice response rate with the objective response of over 50% here, with the swimmer's plot showing some durable activity of that response, which is quite exciting. And then in terms of the AEs, we see the most common AEs here, nausea, fatigue, cytopenias as well. The rate of grade 3 or higher treatment-emergent AEs was about a third. There were discontinuations of about 20% and reductions and dose delays in about 13% of patients. There's ongoing work looking at this drug in various studies. This is a phase 2 ID801 study design. This takes patients with extensive small cell, previously treated with prior platinum-based regimens, and studies 2 different doses of this drug. And then ID8-Lung02 is a phase 3 study of IDXD versus the treating physician's choice for relapsed small cell. So here, patients with small cell, at least 1 prior therapy, including platinum, are randomized to receive IDXD or dealer's choice of topotecan, lurbinectedin, or amrubicin. And so with that, I'll end.
So thank you all for attending. Thank you to those of you online, and to my co-host, thank you so much.
Thank you.
Thanks.